YouTube is live.
Yeah, I got the message here.
Yeah. Okay.
Okay, so should I go back in again?
Yeah, go out and come back in. Good afternoon, Professor Mulenga. Can you hear us? Can you see us?
He's not.
He's not yet been able to join in, unfortunately.
Okay.
He's there on WhatsApp and I don't know what's happening. Trying.
Shall we give him 5 minutes to join and we start at
Yes,
10:35 instead of
Yes,
10:30? Yeah.
Yes, please. Thank you.
Okay.
Thank you for the YouTube. YouTube.
No.
What's happening?
Suppose, how will we know when it's recording? There's a red light coming somewhere, is it? Oh, it's we're live now.
While you're away, Dr. Jami, the messages came up, so it is being recorded now, and it is also live on YouTube. We're going to start in 5 minutes because Professor Mulenga is having a little bit of trouble to join us. We will definitely start at 10:35. Good afternoon, Dr. Shrikant.
Good afternoon. Good afternoon, everybody. How are you all?
We are all fine, thank you. How are you?
I'm fine, thank you. म्हणून आहे तिचा नंबर आहे तिला बघ काल ती आहे ना आपली प्रतीक्षा
We will commence in a couple of minutes.
Welcome, Dr. Mulinga.
Thank you so much.
Good afternoon, Professor Mulenga.
Afternoon, Professor Mulinga. Nice to see you. Actually. Actually, I seem to have lost him again.
Okay, do we have the rest of the panel on board?
Yes.
Yeah, entire panel is on the board.
Okay, we'll start in 1 minute. We'll just give Professor Mulenga one more opportunity to join.
Even Kamal has joined.
Good. Hi, Kamal.
Kamal was in midst of some emergency. His father had fallen and he had got a fracture, so they had taken him to the clinic.
Oh dear, I'm very sorry to hear that. I hope he's okay. Okay, I'm going to commence the panel discussion. It is 10:35. Good morning, good afternoon, and good evening to all the guests and panel members who have come for this panel discussion today. Firstly, a warm welcome from the International Rotary Club of District 1210, England. The club was given its charter on the 5th of October last year, and this is the third project of the club in the last 5 months. I would like to thank firstly all the panel members who have given their valuable time to come and join the panel discussion today. And I would also welcome all the guests and visiting Rotarians and dignitaries to the meeting today. Just a couple of small things. Please keep your mic on mute if you are not speaking. And if you would like to ask a question, please raise your hand. Our convener, Dr. Rajesh Patil, or one of our moderators, Dr. Shrikant Raje or Dr. Nitin Patankar, will be able to assist you with your questions. The session is being recorded as well as it is being broadcast on Zoom and YouTube Live. I wish everybody all the best, and I would like to thank the panel members once again for agreeing to be part of the panel discussion on COVID. It has been a hot topic and has affected all our lives over the last 2 years. We have all had different and personal experiences, and it's a good opportunity to get a panel of esteemed dignitaries who have worked in different countries around the world, in UK, Zambia, Kenya, and UK, Zambia, Kenya, and India, and battling COVID on the forefront. Without much further ado, I would actually like to hand over to our convener, Dr. Rajesh Patil, to carry on with the proceedings. Thank you very much. Rajesh, over to you.
Yeah. Thank you, John. Let me first welcome all the Rotarians, fellow doctors, and the other viewers who have joined for this seminar or a panel discussion on the topic COVID yesterday, today, and tomorrow. To start with, in November 2019, the first case or the cases were reported from the Wuhan district in China. That time they said that it is contained, so that they locked down the city and then they claimed to contain this virus in the city itself, but it didn't. And in February, this pandemic started all over the world, and it reached the level of pandemic. So that today, if I give you the figures, overall in the world, around 422 million people are totally affected, and 5.8 million are dead. The highest number of cases were reported from America. America reported around 80 million of total cases and 958,000 cases dead and 51 million recovered. Whereas in India, 42.8 million people were affected and around 511,000 people died. In UK, it is 18.5 million people who are affected, or around 160,000 people died. And in Zambia, it is 310,000 people affected. Deaths were only 3,942. Whereas in Kenya, it was 332,000, whereas the deaths were 5,633. These are the today's figure which are taken from the WHO side. So considering all this, we had 3 waves altogether. And the COVID was caused by this virus called as severe acute respiratory syndrome, coronavirus. This virus, at till date, there are 5 variants were available: alpha, beta, gamma, delta, and omicron. Out of which, the delta proved to be very nasty and caused a lot of havoc in all over world. And now it is said that the pandemic is ending, and because omicron, which is now in circulation, is quite mild. But today's news, it is in Hong Kong, around 1,000 patients are waiting to get the bed for admission, for getting themselves treated. So we are going to discuss today COVID, what was yesterday, what is today and tomorrow. And we have this esteemed panel of speakers to name Dr. Jami Rao from UK, Dr. Mumtaz Patel from UK, Dr. Professor Lloyd Mulinga from Zambia, Dr. Kirtida Acharya from Kenya, Dr. Amit Saraf from India, Dr. Anand Bhave from India, and Dr. Kamal Ghanshyamnani from India. So I'll ask each doctor to introduce themselves. Dr. Jami, will you please introduce yourself to our esteemed audience?
Indeed. Thank you very much, sir. I'll be very brief. My name is Jami Rao. I'm an independent public health physician. I'm now engaged in teaching public health. I am also a health journalist of recent vintage, if you like. I took it up only after the COVID pandemic started, and I have followed and tracked the epidemic, particularly in relation to the numbers, and specifically in relation to the numbers coming out of India. And I have written several columns on the subject of the coronavirus pandemic, how the vaccine was developed, and how the vaccine policy was rolled out. And that is the reason why I'm on this panel. Thank you.
Thank you, Dr. Jami. I'll request Dr. Mumtaz Patel to introduce herself.
Thank you, Dr. Rajesh. So my name is Dr. Mumtaz Patel. I'm a consultant nephrologist based in Manchester in the UK. And I also work for the Royal College of Physicians as the Vice President for the global side. So, and also as a postgraduate associate dean for Health Education England. So my roles are quite diverse. So as a clinician, of course, I've seen the impact of COVID on the ground and continue to see the developments as they emerge. And in my other roles with the Royal College, as well as in my Health Education England role, we support our members and fellows, as well as all the trainees. So in the Northwest, we have over 7,000 trainees, which we support through the pandemic, particularly with their needs as well to address. And with the Royal College, we have over 40,000 members, and internationally, up to 20% of our membership is international. So a lot of support, hopefully, has been provided during the COVID pandemic, and a lot of experience to share. So looking forward to the event this afternoon with yourselves. And thank you again for inviting me.
Welcome, Dr. Mumtaz. Now I'll request Dr. Professor Lloyd Mulinga to introduce himself.
Thank you so much. I'm Lloyd Mlenga. I'm a professor in infectious diseases from Zambia. I'm the director of infectious disease for the Ministry of Health, and as a result, I'm responsible for overseeing programs for the which are infectious disease in origin. Currently, I'm the clinical lead for the COVID-19 response in the country. So I'm in charge of how to implement the COVID-19 response for Zambia. And since COVID, I've also participated in a number of research regarding COVID and also publications around COVID in the region and also in the country. Thank you so much for having me.
Thank you, Dr. Lloyd Mallika, for joining. Now I will request Dr. Kirtida to introduce herself. Dr. Kirtida Acharya.
Thank you, Dr. Patil, and thank you to the organizers. So I'm Dr. Kirtida Acharya. I'm practicing at the MP Shah Hospital in Nairobi, Kenya. I'm also the National Chairperson of Diabetes Kenya. And I'm an editor of the Diabetes Global magazine. I'm the COVID author in that magazine. And I lecture to the students in the country. So during the over the COVID epidemic time, I was involved with the Kenya Diabetes Study Group in writing the national strategy and guidelines to face this epidemic. And with the Diabetes Kenya, we had to have a call of action as to how the telemedicine and how we would provide support for the patients with diabetes and services, and with the Ministry of Health, how we would roll out programs and have implement our guidelines. And with diabetes and endocrinology, how we would be managing the patients, because COVID and diabetes, we know there's a link. And I think that's the reason I was invited to discuss how COVID impacts on diabetes and endocrinology. And thank you for having me on this esteemed panel today. So I'm looking forward to the fruitful discussion with all my esteemed colleagues today.
Yeah, welcome. Now I'll ask Dr. Amit Saraf to introduce himself.
Thank you, Dr. Patil. It's a pleasure to be here. Thank you to Mr. Shankar as well. I am the HOD of medicine at Jupiter Hospital in Mumbai, and I also head the quality control department at Jupiter Hospital. We actually, throughout the entire pandemic, remained a non-COVID hospital. So my experience, though, yes, in an extent, managing of COVID has been there, because we did have our own share of COVID positive patients. But then I thought even a little bit of insight into how do you manage a patient who has come in for some other necessary medical reason to a hospital in the COVID pandemic, and what precautions you've taken. I am also the MRCP examiner, and along with Mumtaz, we do some work as an international advisor. She's a global vice president. So we've had a couple of seminars with the RCP and the Indian conglomerate about physicians, and we had exchange ideas as well. So it's a pleasure to be here in this esteemed panel, and thank you so much for having me.
Dr. Amit, it's our pleasure also. I'll request Dr. Anand Bhave to introduce himself.
Hello, everyone, and a very pleasant afternoon to all of you. I'm Dr. Anand Bhave. I'm a consulting physician at Jupiter Hospital and at Param Hospital, Thane. I'm a member of the Thane City Task Force for COVID since the last 2 years. And in that capacity, I've tried my best to lend guidance and direction to the anti-COVID efforts of the city. It's a pleasure to be with all of you. Good day.
Thank you, Dr. Anand. Now I'll ask, request Dr. Kamal to introduce himself. Dr. Kamal.
Yeah. Good afternoon and good morning to everybody. My name is Dr. Kamal Gansarnani, and I'm an ENT surgeon practicing here in Thane, India, and I'm a consultant at Jupiter Hospital. During the COVID pandemic, we came across one of the most deadliest infections we could get, and you can say a co-infection along with COVID, and that was mucormycosis. So my role today is to help you and to just give you guidelines on how we handle the situation of that disease during the pandemic. It's an honor to be in this esteemed panel. Looking forward to it. Thank you.
Thank you, Dr. Kamal. Now I have two doctors who are going to co-host this program with me. One is Dr. Nitin Patankar. Dr. Nitin, will you introduce yourself? Dr. Nitin? I think there is some problem with him. Meanwhile, I'll ask Dr. Shrikant Raje to introduce himself.
Good afternoon, everybody. I am Dr. Shrikant Raje. I am actually a practicing radiologist from Thane, but I had a great opportunity from one of the biggest TV channel from India, basically mainly from Maharashtra. The name of the channel is TV9, to speak on COVID on various topics in their prime news. So I had no choice but to study COVID in and out and very well. So COVID dragged me to the study of COVID. And I am actually a practicing radiologist, but I own one hospital, 110 bed at Hyderabad, where we face second wave of COVID very badly. So practically, I have seen a lot of problems coming for COVID patients during that wave. Thank you so much.
Yeah, thank you, Dr. Shrikant. Dr. Nitin, will you introduce yourself?
Yeah, I'm Dr. Nitin Patankar. I'm a physician, and basic areas of interest are diabetes, obesity, and preventing diseases. And I'm very happy to be part of the moderator team assisting Dr. Rajesh Patil for this very important discussion. Thank you.
Thank you, Dr. Nitin. Now, to start the panel discussion with our esteemed panelist, I'll first ask question to Dr. Jami. Dr. Jami, how the government have adapted to the COVID outbreak and how much help they have availed from epidemiologists like you? Dr. Jami, you are muted. Will you unmute yourself?
Yeah, thank you for that. Thank you very much for that question. In general, I think it would be fair to say that most governments around the world have been slow to respond in the early stages. Having started off slowly, they then went into a sort of a denial phase and then reacted to events as they unfolded. Scientific advice, epidemiological advice, and expert opinion and advice was accepted and acted upon, but always, in my view, with an eye to the political consequences of those decisions and those actions. So in country after country, one saw pictures of, of some confusion where there was a lack of a concerted response where ministers and governments in charge of policy worked together with the scientific community and developed a policy after rapid but nevertheless systematic consideration of all the factors that go into making such important decisions. Internationally, there has been an even bigger problem in that there was, at least in the early stages, a lack of coordination in terms of sharing the resources that we needed to combat the epidemic. So there was a widespread inequalities in terms of, where the production facilities were for things like PPE, drugs, and equipment, and where they were needed. And that was partly as a result of the standard arguments, really. America, for example, had withdrawn just before the pandemic from the WHO, had stopped funding for the WHO. And that was sad because that is exactly the kind of international event for which we need a coordinated effort of the kind that WHO can provide and has provided in the past. And finally, just one last point, in terms of the social and economic response to the pandemic, many countries were guilty of following repressive social policies and illiberal economic policies that led, in fact, far from sort of ameliorating the problem, it led to a widening of inequalities. And we are now seeing the consequences of that, where not only is there a wider inequality between countries, there are also wider inequalities within countries, between different sections of society. It's both health inequalities as well as economic and employment and other income-related inequalities have grown. So it's not been entirely a glorious picture to hold up and say, didn't we do well? We did not do all that well in the early stages of the epidemic.
So can you enumerate what were the right things done by government?
They certainly responded actively in terms of sorting out problems like, PPEs. Once they were available, they were given out to the hospitals to sort of tackle the problem. Lockdowns were enforced, sometimes rather harshly in my view. We needed to have taken the people along rather than taken a punitive approach. And they did respond in terms of providing economic aid to the people most at risk of suffering economic hardship to their livelihoods. In terms of extra packages. So Britain was one of the countries where that was done effectively, where people were given were paid 80% of their wages, even if they lost their job because of the falling off of demand for services in the service sector. Many countries have given out food handouts for the poor and so on. America is another extreme example, really, where having been slow to respond, they did throw money at the problem, and I think they did reasonably well in terms of the aid that was given to the poorest people. Internationally, though, the picture is still bleak.
So many countries have declared lockdown. Some countries have they were reluctant in doing the lockdown. We have seen the havoc in Italy at that time when they somebody said let's hug each other, and that was how the thing spread. So don't you think that that was something stupid thing which people did at that time?
That kind of stupidity was carried out throughout the last 2 years. In fact, even now there are people who are saying no to vaccines. Look what's happening in Canada, for example. And there are lots of people who are advocating whatever medicine they can lay their hands on. Trump and Elon Musk were responsible for all the hype and mythology around hydroxychloroquine. And I've written about that in a column where a simple tweet from Elon Musk apparently led to the hydroxychloroquine madness, if you like. Even now, there are anti-vaxxers around who refuse to accept the vaccine, despite Omicron being a milder variant. Vaccines are still necessary in order to prevent the next variant, who we don't know what it will be. It might be milder than Omicron. It might be more severe than Delta, for all we know. So that kind of sort of maverick response has always been with us. What I'm complaining about is the lack of united leadership to combat it.
Thank you, Dr. Jami. I'll ask a question to Dr. Mullinga. Dr. Mullinga, Africa had seen a lot of outbreaks like HIV, TB, and any other diseases. How handling these outbreaks and epidemics have helped you in handling the COVID outbreak in your country? Because what we are seeing in the WHO figures, Zambia and Kenya have reported lowest incidence of COVID infection.
Yeah, thank you so much. Indeed, our country and as our region as well, we've been fighting a lot of other diseases. You've highlighted HIV, there's tuberculosis, there's also malaria. And especially for the HIV program, it has helped us, the experiences we have had with managing the HIV epidemic has helped us in managing COVID. In fact, we have really used most of the platforms we have been using for fighting HIV to fight COVID. There are examples like the testing, most of the testing which we are using for PCR based, we are using the same equipment we use for HIV. And this has in a way impacted negatively on HIV, where viral loads are being done less on HIV because we are concentrating on COVID. It's similarly in testing as well. There are certain platforms we use for testing TB. The Gene Expert, we are also using those same experts to test for COVID. We have used the same public health approach for COVID, and this public health approach has been based on the same mechanism we've been using for HIV. So in a way, having had time to fight HIV helped us to use those same platforms and also the same planning phases we have had for HIV. And even resources we have had for HIV, some were deviated to COVID. And as you know, when you use such mechanisms, then the other disease suffers as well. Yes, we have suffered a lot of mortality, especially for us, Zambia, we have had 4 waves, not 3 waves. We are now just currently getting out of the mild 4th wave, where the Omicron has been the major variant we've been seeing. And even though we had a lot of deaths, I think they are not compared to many, many other countries where the mortality rates have been high. In fact, our mortality rates, case fatality rate has been below 2% overall. Thank you.
Because the mortality rate which has been given by WHO is that you are around 3,942 mortality till date. That is the figure which I got from the WHO. Is it a real figure or it is some sort of suppressed figure? Because I don't think so. All the deaths are
it's
reported.
A real figure.
I don't think all the deaths are being reported, because overall in the
No,
world, in the 5.8 billion people have died. That is what is the WHO's figure is there. But I doubt whether this is a true figure or.
you are right. Of course, our official figures, even today, we lost another patient. So our official figures are 3,943. So there is one in addition to the 3,942. But there is, of course, globally underreporting of these cases. We have had a lot of people who have died in communities, and we have not had access to the data. We have had also in certain facilities, especially during the first wave, where not all the cases we are reporting. So, of course, what we are reporting is what facility deaths. We have also included in the first wave, we are including even those that were being brought in as dead. And once we swabbed them and we found that they were positive for COVID, we were reporting them. But of course, this is a number not reflecting the true deaths that we have had due to COVID or associated with COVID.
Thank you, Dr. Mullenga. Dr. Anand, vaccination is around for last hundreds years, let me see. And vaccination is supposed to prevent the disease, and some vaccines even have helped in eradicating the disease. Those vaccines have been tested for at least 6 to 7 years, but COVID vaccine has been approved for emergency usage. So do you feel that there is any lacuna in these vaccines, as there are many COVID cases reported even after taking 2 doses?
Yeah, that is a question which you have really pinpointed what is probably playing in the minds of many of the citizens. Basically, it is true that the COVID vaccines were approved in a fast track. In fact, they were given emergency use approval. That is not the final approval, but emergency use to begin with. Now, not only that they were approved very quickly, there were new technologies in the COVID vaccines. Only the Chinese vaccines like Sinopharm, the killed virus vaccines, were very similar to the killed virus vaccines used earlier. Otherwise, this AstraZeneca or Covishield in India or Johnson & Johnson, it was a new technology vaccine using a vector virus. And of course, the mRNA vaccines are also extremely new in terms of technology as well as specifically about COVID. But it is not that these vaccines were suddenly brought out of nowhere by magic. The work behind the technology has been going on for more than 30 to 40 years about mRNA technology, and at least 15 years for vector virus technology. So because the pandemic spread so rapidly, there was absolutely no time to approve the vaccine through the normal channels, which takes 5 or 7 or even 10 years. So in order to help humanity to be on time, this rapid processing of approvals of vaccines was done. Even there were new adjuvants used, like our own Bharat Biotech Covaxin is using a new adjuvant for the first time to cause better stimulation and better immunogenicity. So it is true that there is new technology and the vaccines were approved rather fast, but the animal studies and the early trials have not shown any out of the way or very high incidence of side effects. All vaccines can have side effects. So they have saved many lives, and it makes good sense to take the vaccines. As far as the second part of the question, that people have taken 2 doses or even 3 doses and still got infected. The answer to that is that COVID being an RNA virus, which is rapidly mutating, it is changing its structure and succeeding in evading the efficacy of the vaccines. And secondly, it's a respiratory virus. So it's very difficult to block such an infective virus, which is probably the second most infective virus ever after measles. That vaccines are not able to stop all infections, but they have definitely shown a reduction in mortality, which makes sense for all of us to take the vaccine.
So how can you compare this COVID vaccine with the previous vaccines? Whether it is better in form of technology or it is somewhat same in efficacy wise?
As far as efficacy wise, I think it rather than comparing vaccines, you have to compare pathogens, because COVID is so infectious, it is probably difficult to stop it. After the vaccine, within 4 to 6 months, the antibody levels drop and you are at risk of getting reinfected. So it is, say, less effective than a vaccine like, say, measles vaccine, which is a live attenuated vaccine. But it is fulfilling the job of reducing deaths. That is certain.
Thank you, Dr. Anand. Dr. Kirtida, it was seen in our part of world that many new cases of diabetes were detected during COVID infection, post-COVID. And these patients, were diabetic patient more susceptible to COVID, or did COVID cause diabetes? Because we have also seen many cases of pancreatitis in teetotaler patients, means they never had any other reason to have pancreatitis, not even touch alcohol and all those things. So do you think there is any link with COVID?
Sure. So it's like a chicken and egg story, a double-edged sword. We call COVID like a bittersweet conspiracy. So we saw new onset diabetes with COVID. Many patients actually developed diabetes who never had diabetes before in our setup. Many of these patients had even been given steroids. We were not sure whether it was the COVID causing the diabetes or the steroid-induced diabetes. Patients we know with organizing pneumonias had been given steroids when they were unwell, but even patients who had not been given steroids developed diabetes. Actually, there's a global registry now where we are reporting, most of my colleagues here are reporting the COVID ENRIGHT registry. So we are reporting this diabetes. Some of the patients are actually having a transient form of diabetes. Even now I've got a patient who was in ICU. She's gone to the wards, gone home, and actually I've stopped all her medication. And people are requiring even high dose insulin and then orals, and then suddenly, they are off all medication. And if you do the HbA1c, it's normal during the COVID. So COVID is causing lots of, issues with the pancreas, as you're rightfully saying, pancreatitis. It's causing all sorts of havoc. And because this is a new thing, we are getting lots of surprises, what it's doing. And patients with diabetes, yes, are definitely more vulnerable to getting COVID. They also don't do as well as people who don't have diabetes, whether it's people with type 1, type 2, any type of diabetes are not performing as well. They're requiring more admission to, HDU, ICU. They're getting more pneumonia, they're getting more even mortality. And it's not just diabetes, any chronic condition, any NCD. So if somebody has hypertension, obesity, cardiovascular disease, solid tumors, post-transplant patients, elderly. So there's this whole group of people who are not doing as well. Surprisingly, HIV patients in our group, our part of the world, are not doing as badly off. So we're seeing people with non-communicable diseases, especially diabetes, are not doing as well with COVID as people without NCDs. So we really, this is a wake-up call that we need to really take care of NCDs.
So yes. Can we call it that it is this diabetes which came as a post-infection diabetes, or which will remain as a temporary, as a relief? What you're saying, some patients have gone without medications.
In some patients, it's temporary, but in some patients, it seems to, to actually persist. And many patients are not just having diabetes, we are seeing dyslipidemia as well, new onset dyslipidemia. So this virus seems to be doing things to the pancreas, to the liver, to all sorts of, organs. And I think only time will tell. And even the previous SARS epidemic, the post follow-up has shown that there is metabolic derangements that are happening. But some of our patients, it's transient, and in others, it's persisting. So I think it's only time that's going to tell us in what proportion are we going to get permanent diabetes and temporary. The one which is steroid induced, we are seeing in many people, it's remitting.
Thank you,
Dr. So it's a double-edged sword, really.
Yeah. Now, Dr. Amit, as you told, your institution was kept, Jupiter Hospital was kept reserved for non-COVID patient. But we have seen that many patients many hospitals were converted into COVID hospitals, and the non-COVID patients did suffer in the sense that the routine procedures were postponed, or routine admissions which they used to find difficult getting the beds also, even though MI patient or had find difficult to get the beds. So how did you adapt to COVID situation in treating non-COVID patient in your institution?
Well, it was absolutely a challenge because I would like to answer this question by dividing into two things. One, how did we manage the healthcare workers, and how did we manage the patients who were not COVID and not having COVID, but came with other medical ailments. Healthcare workers, when the virus came in 2019, early 2020, everybody was shell shocked, and it was just like, I remember the first time a patient was incidentally found positive in the hospital, and whoever were the staff, nurses, the security people, the doctors and the contact, they were like absolutely what to do and what not to. So first rule of thumb for the healthcare workers was educate and counsel. So along the last 2 years, we've had sessions where we talked to our healthcare workers, gave them right information, had regular, what we called in the hospital as COVID bulletins. So every day in the afternoon at 12 noon, we used to have a seminar where anybody can attend. We used to try to disseminate information. Second, importance of masking. So masking came in new. I mean, nobody was used to it. An average surgeon or an anesthetist may be used to wearing a mask for 6, 8, 7 hours, but you talk to a physician or a security fellow or a nurse to wear a mask for all those hours at work, it's a little difficult. So to sort of teach them the importance of masking, hand washing, to provide hand sanitizers from all in the entire hospital building, to provide level 3 PPEs. So luckily, thankfully, the place where I work, the management was pretty much cooperative in providing level 3 PPE to whoever demanded. We didn't reserve it to places like intensive care or other, whoever was little uncomfortable in working with level 1, we could give them level 3 as well. Then came in that era where for some time, HCQS was found to have a little of benefit in preventing COVID-19. So all the healthcare workers were given once a week of HCQS, maybe the multivitamins played a role. So all that happened in the initial 6-8 months as the virus hit us. When it came to the patient population, I think the biggest challenge was instilling confidence. Hospitals at that time were looked upon centers of disease spreading. People were scared to come to a hospital, as if that going to a hospital is going to give me COVID rather than getting me treated for COVID or something else. So instilling confidence in the sense of thermal checks at the gates. If you're found to have fever, you straight away go to a cordoned area, which we called a fever OPD, and they were checked over there. And if they came positive, they were sent to a COVID hospital. And then we took in only the non-COVID cases. We also had a facility wherein we kept the critical and non-critical suspect patients for a bit, those who had respiratory symptoms and the COVID was yet to come in. And if they unfortunately came positive, they were shifted back. And the non-COVID ones were again, the importance of masking all the time. We kept the relatives we used to have video calls with them. We didn't allow relatives to visit the hospital patients much. The importance of hand sanitization. That's, I think, over the period of time is how, as a non-COVID hospital, we could gear up and probably take care of all these patients. Thank you.
Thank you, Dr. Dr. Mumtaz, if you know that during the first wave, the medical faculty was totally and practically clueless about this pathophysiology of COVID virus. What was the impact of COVID-19 on the doctors and healthcare staff, and how was this moral distress and moral injury exhibited during this pandemic?
Thank you, Dr. Rajesh. So as Amit was just saying, it was scary and very, very challenging, particularly in the first wave. And I guess we all went through those different phases in different ways. But I think, it was a huge test to doctors, healthcare staff, and it tested workers to their absolute limits, I think in lots of different ways, with a significant risk to your own health and well-being, because I think all of us were going through our personal challenges as well, with people being affected around us, friends, family, other healthcare staff as well. So I think, kind of that difficulty with both clinical care, but also your personal sort of circumstances and where the balance lies was really hard. So I think, as you said, we were prioritizing patient care, making very difficult decisions. I remember, kind of signing patients off to kind of for intensive care or not fit for intensive care. And who are we to make those decisions? I mean, I found it really hard. We talk about all the ethics side of things, but then on the ground, when you're doing it, it's really, really, really difficult. And I think the concept of the kind of the moral distress or moral injury is based on that fact. So, kind of that risk from both professional duty, but also personal sort of, kind of your own responsibility. So if I share an example, my father was quite poorly with COVID in the first wave, and he got admitted. And I felt so guilty because you felt I was the only one who during lockdown was going in and out of the hospital, and I probably brought the infection to infect my father. I mean, thankfully he survived, but that kind of constant guilt, kind of leads to this concept of moral distress and moral injury. And how do we tackle it, I guess, is the next factor. So lots of well-being initiatives were being thrown in for doctors, probably later. And then, hindsight is a wonderful thing. I think at the time we were just dealing with the emergency as it was arising. But if you had your time again, I think that support to the healthcare staff in a much more non-judgmental way, because I think there was always that guilt feeling that you were made to feel that if you were supporting, kind of your personal sort of risk versus your professional duty, where does your priorities lie? So well-being initiatives need to be targeted by system change as well. So how the schedules were working, how we were supporting our healthcare staff through it. Lots of, I had partners who died, kind of one of the nurses from intensive care, a husband got it and then he died. And, how do we support better? So I think, much more work to do on that front. And we can talk about that. So I think the concept of that moral injury, moral distress is based on that personal risk, but professional duty kind of factors, and how we deal with it going forwards is something that we could all learn from and hopefully avoid that, kind of in future. Hopefully we won't see anything like this in our lifetime, but I think being better prepared and having that resilience built in better for our staff is really important to protect them. Thank you, Dr. Rajesh.
During first wave, we have seen a lot of mortality in our faculty, because at that time we were not at all protected. The vaccine didn't come. But during the second wave, at least partially we were protected, and then we had that confidence to face that pandemic. Okay, but during the first wave, I think we were all shaken up because we were totally clueless what is happening, what is who is going to get affected, who is not going to get affected, because 85% patient did require anything, whereas the 15% patient which required the problem hospitalization, out of that 5%, those who got admitted in the ICU were quite serious one, So yes. I think that time, what you said, that we were all shaken up during that. What do you say?
Yes, yeah. No, I think it's so hard, isn't it? And I think because we didn't have the vaccinations, I mean, I think now when we get it, you think, okay, we'll be protected and the severity won't be as high. But the majority of people who were getting it, and if you had underlying health problems, I'm asthmatic, my father's asthmatic, or underlying, immunosuppressed patients and colleagues, I mean, they were getting just so unwell very quickly. And I think protecting them better, the PPE, even in England, even in our hospital, was not great. So you have the intensive care doctors wearing the hazmat suit, as I used to call it, the full PPE. And we as renal physicians going with a pinny, little plastic pinny and a mask. And we're seeing the same patients. So you think, why am I not being protected? So we had all these WhatsApp groups of doctors feeling completely, and also wider healthcare staff feeling really dismayed by the whole process and not being supported, and emails being flying to medical directors and nothing coming back. So I think, it really caused distress amongst the healthcare staff of not feeling supported. I think it is better now, but as you said, Dr. Rajesh, we were all learning, weren't we? And I think we didn't really know, but I think clueless is the right word, because despite having a lot of medical knowledge, we were still very unsure how we were approaching it. But I would hope that those things are now much improved and you feel much more comfortable in managing things going forwards.
And to add to our distress was that the PPE kit were not available in that adequacy. Many people didn't have PPE kit and they were just going with a mask, that to the surgical mask, which didn't have any protection, unless until you were wearing N95 mask. I don't think so that cotton mask or 3-ply surgical mask was helping. Thank you, Dr. Mumtaz. I'll ask Dr. Nitin Patankar to take over. Dr. Nitin.
Yeah, thank you, Rajesh. To carry forward this excellent discussion, I would first like to go to Dr. Amit. So as you said that you were managing a non-COVID center, and which is a primary center for tertiary center, not primary center, tertiary center for most of the people in our areas. So one part of this COVID treatment is people have got a lot of doubts about COVID treatment, and they are mostly sure that remdesivir or steroids have caused more problems than how much they have saved a life. So you must be getting now a lot of patients who have undergone COVID treatment, whether it is remdesivir or other variants, antibody cocktails or steroids. So do you feel that now treating the NCDs or all the routine admissions that come to you who are post-COVID, is there any change in your pattern of treatment now? Or what I want to really ask is there any dent made by COVID treatment to the medical management of patients in your experience?
Right. I think, as always, Dr. Nitin Patankar, a difficult question. I'll try my level best to answer it as to the best of my ability. So, as he rightly said, see, if there are two schools of thought, I am in the midst of a very learned audience, and I'm sure some of us will agree that still the treatment is rest, chicken soup, and paracetamol. And some may say it's all about antivirals and the antibodies and the cocktails and blah blah blah. So I think it's two distinct schools of thought. And being a non-COVID hospital, we did have a lot of patients who came in either treated or we had to treat them. So the way I look upon it still is we have a lot of armamentarium. We have supportive drugs which start from prevention in the form of multivitamins to maybe the masking and the non-pharmacological therapies, hand hygiene, pharmacological therapies in the form of multivitamins, vaccines for sure. Therapeutics are your proper antivirals like your remdesivir, favipiravir, the molnupiravir came in recent times. Then you have supportive therapeutic drugs like your steroids came in play. There was a little interest in plasma came in recent times. Then anticoagulants definitely had a role to play. Then came in the recent antibody cocktail, thanks to Donald Trump, which they received overnight attention, and everybody was crying hoarse about the antibiotic cocktail as the miracle drug. The way I see it, to answer what Dr. Patankar was asking me, I think choose your patients well. It's all individualized. I cannot say that everybody and anybody can have a rubber stamp prescription. So anybody coming to me, will I give them all of the above? Absolutely not. I think it's to be decided as per individual case base. That's one aspect of the answer. The second aspect, being a non-COVID, and when these people came in, we had to look into a lot of long COVID complications. So in spite of people having COVID 6 months, 8 months ago, they still had reactive arthritis. They still had respiratory complications in some of them. Some of them had a new onset of diabetes. So those had to be looked into. In spite of the medical condition, they have walked into the hospital. So, for example, somebody may have come to me for diabetic ketoacidosis. And if I don't look into his lungs or his pancreas because he's had a history of COVID a couple of months ago, then I think you lose something there. So even as a non-COVID tertiary center, we still run a lot of tests to look into the other aspects, especially in the patient who's had COVID in the past. Vaccination definitely have been a game changer. So I hope that answers the question, Dr. Patankar.
I have one more extension of this, that people have got a strong doubt that COVID treatment is causing most of the post-COVID problems. And as you mentioned, that even COVID infection itself, though now the RT-PCR test is negative or the virus may not be present, but the damage done by virus is a root cause of complication of many things rather than the drugs. So how will you differentiate, or how will you soothe the doubts in patients' minds?
So luckily, what is to happen? Luckily, in the sense, wrong choice of word. What is to happen was when people come to us with a history of COVID in the past, they were extensively worked up. So, for example, if somebody has done a lipase level in a gentleman during his COVID admission in the COVID hospital, and today he's come to me 6-8 months down the line for a non-COVID pathology, and if I have a lipase on paper today, it's easier to tell him, convince him that, look, you had a normal report when you had COVID, but because probably the virus must have somewhere affected your organ during the way, and this is causing a set of complications in you now. The same applies for the lungs. I mean, somebody with a double-digit score on a HRCT thorax may land up with a lot of lung sequelae, especially if they have not done a good amount of respiratory rehabilitation. So it becomes a little easier to convince patient in the present times, especially if we have data with us, which can compare the present reports to the past reports.
Thank you so much, Amit. We have a lot of more questions for you, but because of the time constraints, I will have to go to other experts. So the next question I want to ask is to Dr. Jammi Rao. It is always said that doctors use a lot of jargons to confuse patients. So even today's times, we have these words of epidemic, endemic, pandemic, and people are like lightly saying that now we are not to worry because now COVID has passed the stages of endemic and pandemic, and now it is going into endemic zone, or India is becoming endemic, UK is becoming endemic. So for common man, can you explain in short that what inference we should draw from these words, and what is the take-home message for us, how safe we are when we say now we have entered into an endemic zone?
That's an interesting question. I'll try and keep it brief and factual and as helpful as possible. An epidemic is when you have an incidence of a disease more than usual or more than expected. So for example, today in India, or for that matter in any country in the world, one case of smallpox would be an epidemic because you don't expect to see a case of smallpox. Thanks to Rotary's efforts and polio's eradication, 5 cases of poliomyelitis in a particular city or village or district in any part of the world now, or a country where it's been eradicated, would be regarded as an epidemic. So an epidemic does not mean large numbers of cases. It merely means more than you would expect. A pandemic is simply an epidemic which crosses borders and affects a large region or almost all of the world. And this particular situation of COVID-19 was indeed a pandemic because no country was absolutely immune unless they were a completely isolated island of its own. An endemic is when you have a certain prevalence of the disease throughout the year and it doesn't vary by much, goes slightly up and down. It may have a seasonal incidence, rise in incidence, seasonal dip again, but then there is a constant level of the disease throughout, and you learn to cope with it. Like, for example, influenza. We've always lived with flu. Every year you get it, and that's fine. It's an endemic situation. There is a vaccine for it. Every year the vaccine changes because the flu virus mutates and changes. Therefore, we get a new vaccine, we take it, and we cope. Does that mean that an endemic is a good thing to have? Far from it. It is not necessarily a good thing to have, because don't forget, India has an endemic situation with regard to tuberculosis and leprosy. So an endemic is not a happy place to be, because an endemic still means that you have to have a concerted, combined public health and clinical response to that particular disease. And that is where many parts of the world have fallen short in terms of making sure that we deal with endemics as and when they arise. Are we now in an endemic stage in relation to COVID-19? Probably we are at the moment, but that doesn't mean we'll carry on being in that situation. The rapidity with which the original COVID-19 virus mutated and became new variants of concern arose and became the Delta wave and caused so much mayhem in April, May of 2021, does suggest that we don't really fully understand the biology of this virus. At the moment, we may be in what looks like an endemic phase. That doesn't mean that it will continue to be like that. And we should be prepared for a new variant to emerge and for it to cause a new set of problems. It may be milder, it may be more severe, but we need to be prepared for it. And that is one of the things which many countries in the world appear not to be doing. We are scaling back on some of the emergency measures that we have put in place, particularly in relation to data gathering, genome sequencing, and monitoring of the course of the disease. These things are being rolled back rather than strengthened. So we need to be cautious about that and urge governments and policymakers to continue to keep a watchful eye and not to become complacent about it.
Thank you so much, sir. Another extension of this question is, it is said that once the virus spreads too rapidly or mutates too fast or creates more variants, it loses its viciousness or it loses its potency. So is it true?
That has happened in the past. So, for example, when the Omicron variant came on the scene, and it was shown to be almost a super spreader kind of virus, in the sense that it was highly transmissible, much more transmissible than the previous version. It also turned out to be a milder variant. But I have not seen any good research that links the two and suggests that there is necessarily an inverse correlation between transmissibility and severity. So the transition from the alpha to the delta variant was not in that direction at all. It was both more transmissible and caused more severe clinical illness. It doesn't necessarily follow, therefore, that the next variant that comes around might be both more transmissible and less severe. It could be both, like the Delta variant. We just don't know, which is why my plea, and many public health people's plea, is for continued surveillance and continued monitoring.
Thank you so much. Now I will go to Professor Mulinga. As Dr. Jami Rao has said, that we will be entering into endemic zone. And as he was saying that to being in the endemic zone is not a very happy situation, because it can turn into more vicious variants or something. But as Dr. Rajesh has asked you, that you have a lot of experience in dealing with these endemic situations. And so it is said in English that forewarned is forearmed. So you have already been forearmed with handling a lot of endemics. So how that experience you are going to utilize to keep this virus, though it may go into an endemic phase, to say under control, or to keep your people protected from this virus. So what is your thoughts on it?
Thank you again. Very tough question. When we look at the two, especially the various diseases we have which are endemic in our regions, when you look at malaria, again, transmission different, HIV as well, transmission different, and also the methods of prevention as well. TB, the same thing. Maybe TB may be similar in terms of transmission, but it poses its own challenges if we are going to have COVID as an endemic disease. Firstly, we need to invest highly in diagnostics. And the challenge which we have with COVID is that it does affect many organs. So as we plan for it, then we would need to look at investing into these other public health aspects as well, including clinical aspects. It's been well discussed here of the metabolic challenges which COVID does pose. So it means you need to invest highly in those. Then we have to identify as well those risk groups, because it may be a variant which may not be as virulent as others, the way we've seen Omicron compared to the Delta or even the Beta variant, but still, those populations which may be at higher risk may succumb to this, which is different from the other diseases which we have had. So it means that we need to invest highly as well in diagnostics, highly also if you have these viruses circulating around, we need to do maybe what may be called reverse isolation. If it becomes endemic, then we need to look at those populations which may be at risk of developing severe disease and highly advised for them to be isolated as opposed to the general population, because these are the ones which we fear may succumb to COVID. So it's a different aspect compared to what we have. I think what we may need to invest in then are issues of diagnostics to make sure that we have screening available and to make sure that we protect those individuals who may be at high risk of getting severe disease. But also, even the vaccination becomes very key, especially in these same populations which may be at disease, the elderly, the diabetics, hypertensives, including the children as well. In my country, we have seen children highly affected with COVID, with the Omicron variant. We've even seen mortality rates high with the Omicron variant. We have seen a lot of deaths with Omicron variant for those with comorbidities, not of course associated with, not likely due to COVID, but COVID has accelerated even the progression of those diseases. So I think it's those mindsets which countries we need to look at and program our officers as well, so that we make sure that we are able to screen and diagnose and also give appropriate interventions, especially focused to those individuals who may be at high risk of getting severe disease. Thank you.
Thank you so much, Doctor. Another question for you. As you were saying that we will need to a lot of investment into diagnostic and treating the other complications or a vulnerable population. But do you feel that we fall short somewhere into public education about preventing of the diseases? Or do you feel that the need for investment into public education, public awareness into these conditions is worthwhile?
Yes, certainly. And I think to me, the key public health intervention, which is important to have, is the vaccination. I think the other issues of, we know that having mask mandates may not work. For how long are we going to have people mask up? We know that our individuals are going to be found in crowded places. So issues of physical distancing becomes challenging. We know that even reporting early to facilities for those that may have a mild disease is also challenging as well. So I think we need to, besides people knowing the preventive messages, we need to invest heavily into vaccination as one of the major public health intervention. Then those that have breakthrough infections are the ones which you may need to concentrate on in managing. Those who may have high risk disease, especially concentration on those. But you are right, we need interventions into public health aspects so that we can prevent disease, though we may not completely prevent all the infections, but at least if we are vaccinated, we may have a population which even when they get COVID, they don't get the severe forms of COVID.
Thank you so much. Now I will move ahead to Dr. Kirtida. So first question is, does a patient with diabetes need to change his medications in COVID endemic period? Or what I say is that, would you require a tighter control of diabetes when the COVID is around? Second thing is, there is so many people say that there is something called as a post-COVID diabetes. So is it a proven entity, or it's just a, say, what you can say, incidental finding? And thirdly, as with your experience, how a patient with diabetic complications, diabetic ketoacidosis, or say COVID pneumonia in diabetic patients. So how serious these conditions can be and how you managed it. So what more resources or what were your challenges in managing these conditions?
So thank you, Dr. Nitin, for those questions. So firstly, patients with mild diabetes, we don't need to change their medication. So they can be monitored or managed at home, but moderate or severe diabetes, we have to admit them. And with diabetic ketoacidosis or severe COVID, we have to put them on insulin, stop their SGLT2 inhibitors or metformin, certain medications, we'd have to stop them. If they have coadjuvant pneumonia, put them on antibiotics, work with our other colleagues, respiratory physicians or internists, or intensivists, sorry. Sugar control, it's good to aim for a sugar between 5 to 10. We don't want glycemic variability, so we don't want hypoglycemia or hyperglycemia. There are many studies that have shown the pre-COVID sugar makes a difference to outcomes as well. Of course, peri-admission sugar is very, very important. So there are many variables, to be considered. But of course, insulin is a hallmark of sugar control. Things like hydration, preventing clots. COVID, there is a procoagulation. We need to put people on Glexane or antithrombotic agents. DKA protocols are followed as per diabetic ketoacidosis, giving intravenous insulin, giving fluids. Sometimes there's acute kidney injury that comes in as well, so we have to involve the nephrologist as well. So basically, we have mortality can be quite high if there's diabetic ketoacidosis. And we really, during COVID, we had a lot of people coming in. Patients were afraid to come into hospital as well. We did a lot of telehealth consultations. So with incipient decay, we could still manage them over the phone, keep them at home, tell them to take oral water. But the threshold for admission was low when there was diabetic ketoacidosis or patients were unwell. They had a diabetic foot. They even had myocardial infarction. We had to decide, have a triage for who needed admission, who didn't need admission. So there is a guideline or an algorithm as to who needs admission, who doesn't need admission. Not every patient needs admission, but equipping the patients with the glucometer, the strips, during lockdown, it is a bit difficult. So even like countries like Kenya, we had to go for their strips, their medication, essential medications. The other question was on, sorry,
COVID diabetes.
Yeah, COVID can cause diabetes. Yes, COVID can cause diabetes. The virus itself can affect the pancreas and cause diabetes. So that is a real entity. So COVID-induced diabetes is a real entity, and it is being recognized. Yeah, and COVID can
question.
Other organs as well, the thyroid and other endocrine glands. So we've had issues with the thyroid gland. We've had patients who are on hydrocortisone, other endocrine issues. As an endocrinologist, I've had patients actually panicking and calling because they've had dysfunction in their other endocrine organs as well. I hope that answers the questions. Or
quickly, what your take on whether every diabetic patient who had COVID infection should be put on anticoagulants?
Yes. No, not every diabetic. Only people who were unwell or had DKA or were quite unwell or hyperosmolar state, somebody having an MI. So it was unwell patients. Not every diabetic needed to go on anticoagulants. Yeah, the hospitalized
because
patients.
There are so many patients.
So many patients were given
Ecosprin.
Yeah, they didn't need that. So there were these prescriptions that were going around where there were so many a lot of medications were being given that actually didn't need to be given. But we try and give guidelines. We actually came out with guidelines quite early on when COVID started as Kenya Diabetes Study Group and Diabetes Kenya. So we were doing online training to the doctors in our country as well, to the GPs and the clinical officers. And we've been having regular CMEs to guide and try and give out the guidelines. And also for patient empowerment, we've been doing online webinars and trying to tell them what needs to be done. But it's always better to let the patient know if there's any doubt, they go to the nearest health facility to be managed.
Thank you, Dr.
I hope I've answered adequately.
Thank you very much. Now I will go to Dr. Kamal. So many cases of black fungus were detected during the second wave. So I'm sure you will explain us why this black fungus suddenly came into market and why it is called as black fungus. Usually it is said that fungus is black. So if there is like a white fungus, black fungus, are there any variants? And why this suddenly came into second wave?
Okay, so black fungus, what we were commonly calling the variant which happened, or you can say the infection which happened during the second wave, the deadliest wave, the Delta wave. Basically, this fungus has been in the air. It's been in the air for decades. It is something not new. And why is it called black fungus? Basically, what happens is this fungus is basically called mucormycosis, which is the one which invades in our body. It's been there in the soil and in the environment for many years. And we've been seeing cases of mucormycosis over the last few decades and all that. And during the second wave, what happened was when we were dealing with the patients of COVID, let me just come back to one more thing, and that is that why it's called black fungus. I'll answer with that first. It's the way it looks at us. When you look at the patient who is having this infection, the fungus invades the blood vessels and causes completely necrosis. Necrosis means it makes the tissue completely dead. And that dead tissue appears black when you look at it clinically. Hence the name black fungus. There are variants. There is white fungus also, which is called Candida albicans. But black fungus is very, very lethal and fatal. If not detected early or not treated adequately, it can result into the death of the patient. During the second wave, when we are fighting the deadly variant of Delta, we had a lot of issues that we were coming across. We knew that COVID was already affecting and causing a change in the respiratory pattern. People were getting a lot of hypoxic, it was infecting the lungs. We saw that the patient had a lot of altered, you can say, blood sugar levels, which are getting a bit challenging for our physicians to maintain. And this is what the black fungus wants. It wants an immunocompromised patient. It wants a patient who has comorbidities. It's been there. So any patient who was having COVID, so you can say it was a scenario of a patient who was supposed to get black fungus was an unfortunate one. First of all, an immunocompromised, whether he had diabetes, he had some liver disease, a kidney disease, or you can say any other associated comorbidities like blood malignancies or undergone any kind of transplants. And if he suffers from COVID, for example, the deadly virus causing hypoxia, that is decreased blood oxygen saturation, along with it, the mainstay of treatment that was corticosteroids at that time, which we are giving to a patient, was causing a lot of changes in the, you can say, blood glucose levels. Blood glucose levels, you can say the diabetes, and if the patient was going into a diabetic ketoacidosis kind of a state, was basically with a high glycerol content of in the tissues, is a very favorable condition for the black fungus to thrive and grow. And that is where, along with it, we also saw the patients of COVID had increased ferritin levels. So these are all very good factors for the fungus to grow. The fungus is a normal fungus in the air, which we are inhaling day in and day out. And because of the immunocompromised status of the patients that was there, COVID, comorbidities, under treatment, though they were coming out of COVID, they were recovering of COVID, unfortunately, were getting infected by this thing. So we called it an endemic in a pandemic, actually. We saw a sudden rise, a sudden incidence that was maybe around 3 to 5 cases per year, which we were seeing earlier. We were seeing almost 10 to 15 cases per week, which was very, very high. And the humid and hot conditions are highly favorable for this fungus to thrive and grow. So that was one of the other reasons that we saw a sudden surge into the, you can say the rise of this black fungus during the second wave of COVID. Now, when these patients presented to us, they used to usually present with, you can say, nasal congestion, a unilateral headache. Sometimes they came to us with loss of vision of one eye, the eyelids drooping. Some came with altered sensorium. And whenever, as an ENT surgeon, we were at the forefront of looking at these patients and treating these patients. So the challenge was us to treat the patients through its COVID scenario and also to treat it fast and as early as possible. Because the mainstay of treatment of this patient would be to give them medicine and to remove surgically as much as dead tissue as possible. Why remove dead tissue? Why operate such patients? Because in the first wave, when we saw patients who needed surgery, we had to be very, very careful in giving them general anesthesia. It was not indicated unless it is not life-threatening. And as I said, black fungus or mucormycosis is life-threatening. If not detected early or treated adequately, a patient is, you can say, is bound to die. Is as bad as that. We have lost patients in the last wave due to mucormycosis, though they have recovered from COVID. So that's been the scenario out here. And treatment, yes, surgically we have to remove as much as dead tissue because the medicines that you're going to give to treat this black fungus doesn't reach into these areas. That's the problem. So medicines could vary from injection amphotericin, which is the mainstay. Unfortunately, they are again nephrotoxic. That means they affect the kidneys. So again, you have the challenge of maintaining their kidney status and see to it that doesn't affect the kidney function of the patient and to remove surgically as much as possible.
Yeah, and secondly, I want to ask you, what is the story of zinc and mucormycosis?
Sorry,
initially, everybody was given zinc, then they suddenly asked to stop zinc. So what is the scene?
Actually, there was not much of theory to support that, whether zinc is affecting or not, but then that's why we didn't give it or we didn't continue it too much more into it. But as I said, treatment-wise, surgically and the IV antibiotics, amphotericin, and later on, isoconazole was given and treated much more effectively.
Yeah. Thank you, Kamal. Thank you so much. Now I will come to Dr. Anand Bhave. People are now literally, at least in our part of the country, people are really enjoying that now it is Omicron, and Omicron is a milder variant and we are now protected. So it's like live Zingalala. So there are so many people who are saying that Delta is a history and Omicron is a present and future. So now we are not to worry about COVID. Let's get adjusted to COVID and live our life happily. So what would you say?
Yeah, actually, it is not just that Omicron is everywhere and Delta is totally gone. That's not right. Two surveys were published from the city of Pune in Maharashtra, and they found that roughly 90% of the cases are Omicron, but there are still 10% cases with the Delta variant lurking around. So it is not true to say that Delta is totally gone. And the second point about this Omicron is that is it the virus itself which is mild? Yes, but it's not just the virus. We have to understand that India has already gone through two waves. The second wave was especially devastating and widespread. So India, being an overcrowded, overpopulated country, is practically in a sort of a hybrid immune sort of state by now. The sero surveys conducted in city of Mumbai showed that almost 90% of the people had antibodies to COVID. Same situation in the city of Delhi, and in our own Thane city, again, 90% of the people had antibodies. So with such a strong first and second wave, plus in India, fortunately, there has been a good acceptance of vaccines on the whole compared to the rest of the world. And so many people have both been vaccinated as well as infected in the past. So with this kind of immunity, for India, Omicron proved to be mild. But that is not the case everywhere. As we are seeing Hong Kong now, it is spurting in cases. Omicron is the dominant variant, yet hospitals are getting full and patients are in ICU. One of the reasons is that Hong Kong, the senior citizens have been rather reluctant to take vaccines. So there are a lot of vulnerable population in Hong Kong. And for those who have never been infected before, those who have not been vaccinated, and those who may have comorbid conditions, Omicron is not necessarily mild. So definitely we should not drop our guard totally, and we should take some sensible precautions. Masking and vaccination are still indicated.
And last question to you, Dr. Anand. Will there be a stage where we don't need to do the RAT test or RT-PCR? The patient comes, tells you the symptoms, and you will diagnose COVID and treat. Do you think such a possibility?
Yeah, because even today, if somebody comes with upper respiratory symptoms, then COVID is the most common sort of presentation currently. It is still commoner than flu and other similar respiratory syncytial virus and etc. So we will probably come to a stage like that. Now we have some drugs which are effective for flu as well as for COVID. So those might take the center stage in future. Yes.
Thank you so much. Thank you, Dr. Anand. Now, my last question is to Dr. Mumtaz, because I'm seeing Dr. Shrikant, who last 3 years, he has been answering questions, and he was deprived of the opportunity of asking questions to others. So he is raring to go. So I will be having my last question to Dr. Mumtaz and then hand it over to Dr. Shrikant. So Dr. Mumtaz, you being a nephrologist, and as the speakers have mentioned that many times the people were getting, their kidneys were getting affected or they were going into renal shutdown. And I don't think anywhere in the world the dialysis facilities were more than the need or more than the demand. And so this must have been a real extra burden of dialyzing COVID patients who, and in already there are patients who are on chronic dialysis. So what were the challenges you faced? Whether the non-COVID patients accepted the same facility being provided to COVID patients or COVID patients going there. So we would like to know your perspective on this.
No, absolutely. Again, really challenging times, and particularly with the first wave. I think we've got better with the subsequent waves, but the first wave in particular was a major, major challenge. And because, as we were discussing earlier, a lot of the patients with COVID were deteriorating, going to intensive care, high dependency, multi-system, multi-organ failure. The dialysis requirements were really, really high. And I think staffing was a major issue. So we had the machines and we just about had the beds, but the staffing, because we have the same staff on our dialysis wards who normally would then manage the acute patients as well. So at one point we had capacity of over 250 patients on intensive care, of which over 60, 70 patients extra were needing acute dialysis, which were our non-chronic kidney disease cohort. So it was more staffing and how you go about it, and isolating as well. So if patients were testing positive, then isolating patients in bays as well. So all the routine surgery patients and things were all suspended. So we didn't have the post-op sort of patients requiring sort of additional dialysis and things. So that helped a little, but it was mainly, kind of the demand on the nursing staff as well as the, kind of the resources aspect as well. And we were cohorting patients who were our normal patients who were testing positive. So we had hot sites and cold sites. Amit was referring to that from the hospital side, but we had the same situation for dialysis patients as well. So our satellite units were our cold sites. So away from the big centers, we had other, kind of units which were providing dialysis for the non-COVID patients. But also for our in-hospital ones, we had to reduce the frequency. So some patients were now, the chronic ones were being dialyzed twice a week rather than 3 times a week. So yeah, lots of juggling and staffing, kind of major issues of trying to support. And a lot of nurses, poor things, were doing double shifts just to kind of make sure that all the patients were getting the dialysis. So challenging times, though I think the subsequent waves have reduced in severity. So less acute patients needing dialysis, and also our management is slightly better of how we've done things as well. I hope that helps.
Yeah. Another last question to you. I was preparing or inquiring with people that what would you like to know about from this kind of a expert panel discussion. So there was an old nephrologist who mentioned that in their times, peritoneal dialysis was a predominant dialysis method. And if the modern nephrologists, if they are falling short of dialysis machines, why they are not going back to peritoneal dialysis for serious patients? So what would your comment on this?
Yeah, no, that's a really fair point. And Manchester was one of the biggest peritoneal dialysis centers when I was training in the 90s and in the early 2000s. So 20 years ago, over 500 dialysis patients were on peritoneal dialysis, whereas now over 500 patients are on hemodialysis and only 80 or 90 peritoneal dialysis patients. So we did put more patients through peritoneal dialysis. I think it's in the acute phase, there is a room for a peritoneal dialysis, and we are, even during COVID times, but it was then getting the PD catheters in, which was another procedure, and then more risk of COVID and things. So that was a challenge, but we did put a few more patients through peritoneal dialysis in the acute stage. But in Manchester, we've written up quite a bit around sclerosing peritonitis and things. So it's more the longer term problems with PD that are there. So we use it as a stopgap in acute dialysis settings and as a short-term dialysis option, but not longer term because of all the more longer term complications. I hope that helps.
Thank you so much. And I will hand it over to Rajesh before it is taken over by Dr. Srikanth. So Dr. Rajesh, over to you. I think Rajesh is busy in something. Dr. Srikanth, can you take over?
There was one question which came up on the chat box. I'll ask this question to Dr. Anand. The question goes like that. Whether if you are vaccinated or not vaccinated, if you still get COVID, you are going to transmit this virus. So is there any difference between the person who is transmitting COVID and taking COVID, though they are vaccinated?
I think there are not enough studies to document whether the transmission is actually reduced by vaccination or not. So at present, it's difficult to answer this question. If you have been infected, whether if you are vaccinated, you have a lower viral load, and whether you excrete the virus for a shorter period, I don't think that has been proven.
Because many countries have made a vaccine mandatory, and even for the travel, they have made it mandatory. And in some countries, some recognize this vaccine, some they don't recognize. For example, the Covaxin, which was Indian vaccine, was not recognized initially. Even Covishield, which was Oxford vaccine, initially Britain didn't recognize the vaccine at that time.
No, I think it was not the vaccine. They had issues with certification or verification of genuineness of vaccine certificate. The vaccine itself was recognized. Covishield was recognized, and they corrected the error later on.
Okay, and okay, thank you very much. Will Dr. Shrikant Raje to take over?
Thank you so much, Rajesh and Nitin. My asking question is really a new thing for me because I have been answering only so far. So this is a new challenge for me to ask a question. And my segment of population was a layman. Here there are allied doctors and highly learned people where you have to answer. Really, it is a tough thing to answer. So I appreciate it is going great now. Now my first question is for Dr. Kirtida. How were those ladies who conceived during the COVID and had a gestational diabetes were managed? Apart from the diabetes, were any other endocrinal problems exaggerated during the COVID in such patients?
Okay, thank you. Thank you, Dr. Thank you for the question, Shrikant. So basically, diabetes in pregnancy and gestational diabetes has been a real challenge. And pregnant women are more prone to getting COVID and having complications as well. So basically, there is a paper that came out from Africa and India. I was involved in writing that paper with Dr. Priya and Sarita Bajaj and some of my colleagues. So if there's a reference to that, but basically the guidelines in pregnancy, gestational diabetes, first of all, these ladies are very, very anxious. So during COVID, we tried to reduce their hospital visits. And if we can do things by telemedicine, we do it for these patients. But sometimes we do have to see them. And if there is mild COVID, we don't admit the patients. But if there is moderate or severe COVID, we do have to admit some of these patients. There is a need to allay anxiety. Sugar monitoring is very, very important. So equipping the patients with a glucometer is important. Nutritional advice is important. Hydration is very important. If the patients are diabetes in pregnancy or gestational diabetes, metformin is not, or any sulfonylurea, we don't want to use it. So we put the patients on insulin. We want to get good sugars. And of course, we want to work very closely as diabetologists with the obstetrician. And sometimes the patients also need, they need antibiotics and need glucocorticoids. During admission, there are issues as well if there is, if there is a need for admission. So we have criteria for when we need to admit some of these patients. Otherwise, most of them are managed at home. And there are guidelines as to when admission is necessary, when we can manage them at home. And most of the times the outcomes have been favorable because one good thing about pregnant women is that they're very compliant with the instructions. So we've been following, there are guidelines that are out there and for all the countries, and outcomes are generally good if the protocols are followed. Regarding the other endocrine issues, COVID affects all the endocrine system except for maybe the parathyroid glands. So besides the pancreas and diabetes, it affects the pituitary gland, the hypothalamus, affects the thyroid gland. So this thyroid, you can get thyroiditis, you can get sick euthyroid syndrome like transient, and that corrects as well, auto corrects. The COVID virus can cause both hypo and hyperthyroidism, which can be transient. So we've been seeing a lot of dysfunction in the thyroid gland because of the COVID virus itself causing, issues like a thyroid, because of the cytokines being produced. With the adrenal, we can get adrenal issues with during an acute COVID infection. So the hydrocortisone doses have to be titrated accordingly. Most of the times we've had to increase the hydrocortisone doses during an acute COVID infection. Even testosterone levels have been affected in men post-COVID. So basically, the whole endocrine system is being affected during COVID. It's still early days, so as endocrinologists, we are really, trying to document and see what the COVID virus is doing to the endocrine system per se. But yes, COVID is a real game changer. So yesterday, today, tomorrow, it keeps changing. The variants keep changing. And what it's doing to the endocrine system outside of diabetes is also very interesting for most of us. But pregnancy and pregnancy outcomes, diabetes in pregnancy, gestational diabetes, we've really had to monitor our patients closely. And there have been issues of issues with fetal loss and maternal loss worldwide. So we should not take this lightly even now. And patients have to be guided what should be done. Thank you. I hope that answers the question.
Yeah. We had some cases of orchitis, and there was one talk for the channel asked me to speak on the infertility in the male due to COVID. So how serious you think that issue was? Have you come across with such a challenge anytime in your endocrinology practice?
I've had two patients who have had orchitis, and it's a known phenomena. So I said, as endocrinologists, I think COVID has not spared any endocrine organ, and it's really giving us, shocks as to what this virus is really affecting all the endocrine organs. So we really need to be prepared, and we need to monitor. And if a patient comes to us saying these are the symptoms, we check. A lot of things, thankfully, have been transient, or we've been able to handle them or treat them. But the patients need to tell us if what they're feeling, and we treat according to what they are presenting with. So some of the things have been transient, some have not been transient, and we have had to treat and follow up.
Thank you so much. Thank you. Very kind of you. Next question is for Dr. Kamal. Dr. Kamal, did you see any case of mucormycosis in the third wave? And what is the probable reason for decline in the number of mucor cases in the third wave?
Thank you, Dr. Rajay. The thing is that so far we haven't seen any case of mucor, luckily, and we are thankful for that. And I think the reasons could be because we are not seeing much of pulmonary involvement right now in the third wave, the Omicron, except for the patients who are unvaccinated and comorbid, but not much of them. So many of them are having hypoxia. That could be one of the reasons. The other thing is even the altered sugar levels, which we are seeing patients in the second wave going into diabetic ketoacidosis and all that, even they are not very much rampant right now. So they are also not having much of altered sugar levels. So these two factors are one, which I feel are important. Also, I feel we are right now in that part of the phase of the year where the months are pretty cooler and nice for us. So environmentally also hot and humid is what we look for the development of the fungus in case of the disease. So I think these 2-3 causes are the ones which I'm seeing that that's why we have less incidence of the black fungus that we call it at the moment in the pandemic. And to just add one point, Dr. Nitin had asked me earlier about the zinc supplements. We never really did any study. Those zinc say that whenever you have a high level of zinc and that causes the fungus to grow, but we never really had a chance, or we never really did a real study to understand whether there was any high level of zinc in the blood, which was causing also the growth of mucor at that moment. So that just answers it.
Thank you so much. Dr. Kamal, in some vitamin C now, zinc is added to prevent a common cold. And is there any role of zinc in the integrity of the mucosa of the PNS, paranasal sinus?
Not actually, sir.
Prevention.
Not actually that we have come across. Ratan zinc is not very much adequately, depending on the ciliary functions of the nasal mucosa. So not really much studies that we have come across which could determine the integrity of the functioning of zinc in these aspects at least.
Thank you so much. My next question is to Dr. Anand. People are getting COVID in spite of they have been vaccinated. So why should I take a vaccine? And vaccines are said to cause side effects. So why should I take that risk? Now I tell you my story. I took 2 doses of vaccine, and because of vaccine, I suffered more than any time due to COVID. So why one should take that risk? Dr. Anand?
Yeah, this is a question, the answer to which should be known widely to everybody, not just to doctors, but to all lay people. It is true that people can get infected by COVID even after being vaccinated, even after 2 doses, or for that matter, even after the 3rd dose, as we saw in Israel, that even after the booster, there was a spread of COVID. But it is equally that data available both UK or US or even from India, that if you get COVID after you have been vaccinated, the chances of mortality, morbidity are much reduced. And I don't think there's much doubt left about this. And this is sufficient reason that vaccination has to be considered. So what is happening? So another question similar to this that is being asked is that even say when a mutation occurs, the monoclonal antibodies are not working against the new mutation. Then why will vaccine work? So the answer to that is a monoclonal antibody is very specific, and it will act only against one and only one sequence of amino acids on the surface of the spike protein. Whereas our immune response is polyclonal. That means when you inject a spike protein or a vaccine, then the human body makes antibodies against many parts of the spike protein. So it's a polyclonal response, and some antibody or the other is going to attach and is going to reduce the impact of the virus. Your immune system will be more prepared, your T cells will be more prepared, and they will not allow the virus to get out of hand. It will not allow the uncontrolled multiplication of the virus and control the disease earlier. So that is strong enough reason to get vaccinated. Now, what about side effects? Now, obviously the risk benefit ratio, if you see, will be very, very, sort of rewarding for the older population, the comorbid population. That if somebody older than 60 or 70 gets COVID, somebody who has diabetes, obesity, ischemic heart disease, cancer, they get COVID. The risk of mortality is definitely measurable and it's present. So for them, there is absolutely no question that the risk of getting COVID is far higher than any risk or fear that they may be getting, holding about taking the vaccine. The question comes about younger people. Now, say somebody who is 30, and we know that younger the age, the risk from COVID is less. So should they also take a vaccine? But answer is yes, because we have all seen, even young people in 25, 30, 35, 40 years old who have unexpectedly landed up with severe COVID pneumonia and even died. So it is not that COVID spares the young totally. That is a misconception, and we must vaccinate even the young, because the risk from the vaccine is extremely low. Yes, everybody gets fever, there is arm pain, there's discomfort, but the risk of serious side effect like a neurological side effect, transverse myelitis or radiculopathy is very low. 1 in 500,000 people get that. The risk of say myocarditis in younger people with mRNA vaccines, yes, that is a little more sizable, say 1 in 25 to 30,000 among the young males. But even then, it is a mild and a rare kind of side effect as compared to getting COVID. So the answer is you should take COVID. Risk-benefit ratio is in favor of taking vaccines.
And besides that, it helps in going to the malls and cinema theaters also. So
Yes.
one must take vaccination.
It's a passport for you.
Passport to everywhere.
Correct.
Thank you so much, Dr. Anand. Next question is to Dr. Mulenga. How has been the vaccination program? How the vaccination program progressed in your country, and what were the challenges?
Thank you again, Doctor. We really have had a lot of issues with the vaccination program. Now, you know, for Zambia, we started vaccinating in April last year. This is after we're expected to have started in February. But again, because of a lot of myths surrounding vaccinations, and especially COVID vaccines, the rate at which it took for development of the various vaccines, people were very hesitant. And the leadership, the political leadership, said we didn't need to go in and implement the vaccination program until after wide consultations. So this took about 2 to 3 months. So again, that was a time where we lost. And the time that we are starting, it was now just before getting into the second wave. And really that had a lot of a negative effect, because I think the conversations which went on for a long time without making the decisions made people not trust into the vaccination program. When we started, largely the people that went first to get vaccines were people of Caucasian origin, and we had people of Asian origin. In fact, the indigenous Zambians, there were very few of them. They were skeptical, especially with issues around that maybe these vaccines are meant to kill us. These vaccines may make some of us infertile, you know, infertility issues. There were also people who thought, especially when there were issues to do with the thrombotic episodes associated with some of the vaccines, the AstraZeneca, then the J&J, that led to people just thinking that the vaccines coming into the country and being given to the people were just meant to kill the people. So unfortunately, and I'm saying unfortunately, when it came to the third wave, when we had the Delta wave, a lot of people died. We ran out of space in the hospitals. We did not have oxygen capacity in the hospitals. There were times when the 3 trusted hospitals where we have piped oxygen, the plants failed. And people saw a lot of deaths. Our mortuaries were full. And that led to a number of people now coming to be vaccinated. We saw a rise of more than 80% with people now coming for vaccinations. Then Zambia, we have changed the leadership. We have a new government. So when the new government came in, again, the head of state had to relaunch the vaccination. So that gave also an impetus to people to get vaccinated. And then we introduced the booster vaccines as well. Then we started now vaccinating children from the age of 12. And it's just within the past 3 months, that's when we have seen an increase from 3% vaccine coverage to about now 24% vaccine coverage. We have an ambitious target of reaching 70% by June. I don't know if we'll be there. But again, when we have seen the cases reducing in the 4th wave with the Omicron variant, with cases reducing, even the number of people coming for vaccination has also reduced. So it's been a mixed pattern for our country on how the vaccines have been received. Thank you.
Thank you so much, Dr. Mulenga. Over to Dr. Amit. I want to ask Dr. Amit, is it advisable for most categories of the people to take the COVID vaccines? However, there are some categories who should not be taking. Who are they and why they should not be taking?
Right. So the way I can look upon this question is contraindications to COVID vaccination. So like any medical answer, any contraindications are divided into 2 parts, absolute and relative. I think the absolute one, which universally everybody would agree, is a person who's had a past history of absolute severe anaphylactic allergic reaction to the vaccine, similar vaccines, or vaccine components like the neutralizing agent or the stabilizing agent. Those are the ones we are very, very skeptical to give. Second, worldwide, even in the US and India and everywhere, I'm sure this panel will agree, even till date, the neonatal age to the first decade of life, the vaccine has not been given. It's not a contraindication, but people are a little skeptical to give it into this younger age group. Beyond the age of 10, mostly 12 onwards is given in most of the countries in the world. That's the absolute one. The relative, I can just think of honestly one person who's having a real thrombocytopenia. You rather would want to correct the thrombocytopenia before injecting him intramuscularly with a vaccine shot. But having said this, and because we have a lot of delegates from cut across the entire globe attending this, I think the loud and clear message is let your physician decide. You need to take vaccine. You need to go to your physician. He is the best person to decide for you what is to be done regarding vaccination. So don't shy away from getting vaccinated. Thank you.
Very nice. Thank you so much, Dr. Amit. Next question is to Dr. Mumtaz. What were the lessons learned during the pandemic? How can we better support the well-being of doctors and healthcare staff during the pandemic?
Thank you, Dr. Shrikant. So I guess we're all learning, aren't we? And I think, things could always be better. So I think many lessons learned over the course of the pandemic. And I think thinking from a system approach to try and better support our staff is really important. So I know from my own experience, lots of wellbeing initiatives were being, offered to individual junior doctors, senior doctors and things. But unless you think about it from an organizational culture perspective, you need to change how we are expected to work and what we need to do to better support the individuals. So a more of a system level approach. So, looking at work schedules, providing that flexibility, offering support, not making people feel guilty. I was talking about the moral injury aspect before. So building on more support rather than causing, more agony and more distress, over time as well. And then that shared responsibility. So who takes the responsibility for protecting the well-being of the doctors and the healthcare staff? So it should be at a system level. So organizationally, but also so the managers shouldn't be putting always pressure on the individuals. It should be that support should be provided at the same time. So meeting targets is important, but providing that support. Otherwise, people are leaving. We have so many doctors. We had a few junior doctors who took their own life last year. Lots of issues around anxiety, depression, people leaving the profession. So surely it's so important that we have a higher level approach to support people better. So I think peer-to-peer support is really important. Networks is important, but then wider organizational and system level support to try and better protect our workforce. Otherwise, people will leave and getting dismayed by the whole, pandemic, as well as the wider issues as well. I hope that helps, Dr. Shrikant.
Okay, thank you. Thank you so much, Dr. Mumtaz. Next question, last question, Dr. Jimmy. It could be said that the pandemic is gradually coming to an end. Do you anticipate any further waves in the future?
That is an interesting question, and it is linked to our understanding of the Omicron variant and how it has been spreading around the world. There are different views on this. One view is that this is just another variant and another variant might come along at some point. The other view is that if you view the Omicron variant as particularly in light of the speed of its spread around the world, then you might come to a slightly different view, which is that the Omicron variant is now so widely prevalent around the world that we have not yet measured the real incidence of the Omicron variant causing infections. And that is because we have scaled back some of the testing procedures and so on because of economic imperatives and so on. That is not to say that the Omicron variant is going to be anywhere near as deadly or as problematic as the Delta wave. One estimate in the Lancet recently was that there are something like 125 million cases each day around the world. If you take population surveillance measures, not upon infections being reported to hospitals and doctors and clinics and so on. So the proportion of the symptomatic cases to the overall infection is very much lower in the case of Omicron. And if you take that view, then indeed we may be coming to the end of the Omicron or to the end of the COVID pandemic cycle. The bigger question, of course, is what do we do here on in? And one of the answers that some people have recommended, some very good thinking experts have recommended, is that countries where there is already a high level of vaccination Further measures like improving the vaccination rate even further, ramping it up very rapidly, may pay off, may have very, very little dividend to pay compared to countries where it has not been, where vaccinations have not penetrated the population considerably. So long as we can continue the vaccination program, so long as we can continue the mask wearing and taking sensible precautions, keeping safe distances, not attending large events and so on, so long as those are kept within certain reasonable levels of personal action and control, then we may well be seeing the end game of it. That is one view. But your question was about, are we going to see another variant coming, another wave of the infections coming on? Well, that I'm afraid is rather more difficult to answer with any degree of confidence. The consensus view of experts seems to be that we may not see it, but then that was what we said way back in December. Nobody would have anticipated such a serious infection hitting us quite so dramatically as over the last 2 years. So we'll have to wait and watch on that situation and keep a continued watch on viral isolates and also on genome sequencing.
Sir, can we say herd immunity has come, and whether herd immunity can end this pandemic, endemic and everything? There must be a great herd.
Indeed, I mean, it is the levels of immunity which is preventing us from seeing what we saw in the Delta wave. You see, and don't forget, immunity is not a yes/no thing. It's not like either you have it or you don't have it. It varies, and we may have immunity to symptomatic infection, but we may not have immunity to mild infections. It's almost like the common cold. We've always had the common cold with us. We've always had the flu around with us, and we've learned to cope with it. Likewise, immunity is a continuous spectrum. We don't know exactly what we can do to improve it generally, but we know specifically that vaccines work, and that in a previous infection would confer some immunity. So even in the previously infected, the vaccine further enhances immunity to a level at which symptomatic infections become very much less likely.
Sir, vitamin D played a very important role in immunity. Can you enlighten something on this?
I am less convinced of that. The vitamin D saga, the fact of the matter is as follows. Most people are vitamin D deficient. Most women are vitamin D deficient. In Britain, for example, in northern climates, in temperate climates, vitamin D deficiency is widely prevalent. The idea that we have that it is the vitamin D deficiency that has caused the pandemic is in some ways fanciful. There's little evidence that taking vitamin D would prevent getting the COVID-19 infection or the coronavirus infection or the illness COVID-19. Yet it has taken off. Am I saying, therefore, don't take vitamin D? Not at all. Taking vitamin D in small doses is advisable, possibly for everybody, all of us included, because most of us are not exposed to the amount of our diets are poor in vitamin D. The vegetarian diet is particularly poor in vitamin D. Sunlight exposure is not as adequate as we thought it was, particularly in northern climates. In India, that may be less so. But nevertheless, so should we take vitamin D? Yes, we should. Will it solve any problem in relation to COVID-19? Probably not.
Thank you so much, sir. I hand over the session to Dr. Rajesh Patil.
Thank you, Dr. Shrikant. My next question is to Dr. Anand. Dr. Anand, now Omicron is said to be milder variant as compared to Delta variant. So should we still take a booster vaccine?
Yeah, the purpose of the booster is not just limited to escaping from Omicron. Actually, the booster is not going to help you escape Omicron. It's not a Omicron specific vaccine. The purpose of booster is this, that after course of vaccination, the antibody levels which maintain well for 4 to 6 months then begin to drop over a period of time. So when the antibody levels go on dropping, then they are no longer able to protect you from infections, even though you are protected against serious disease and major mortality and morbidity. So further, we are expecting that COVID is going to be with us almost for the long term, and we need a level of immunity to guard against the serious illness against any variants which may come in future. So there were some studies which say that if you have been infected by Omicron, you develop a range of antibodies which may even protect you against Delta, for example. So especially for the elderly, for the people with comorbid diseases, and those who have not had Omicron, they must take a booster. Now, if you have been vaccinated twice, you have been infected with Omicron, then you can wait. You can probably wait for 3 to 6 months and not immediately rush for a booster. Otherwise, the booster is a good idea.
That means that every year we'll have to take a booster dose because
it is possible.
Probably
It is quite possible. And people in India have not taken flu vaccine that seriously. You know, there are not so many people who take annual flu vaccine as compared to, say, US. But COVID booster annually is probably going to be a reality.
But what about the memory cells? Does this not have go into the memory, and then as and when necessary, the body will produce the immunoglobulins?
Yes, that is true. What you're saying is that memory T cells and memory B cells are long-lived, and they may be able to protect us for years to come. But the thing is that how will we know? You know, rather than taking a chance with that, I think the way the pandemic has caused so much of morbidity and mortality, the safer course of action, at least for the first few years, would be to take a booster. And you will have probably modified vaccines. The boosters may be modified according to the mutant strains that we find.
So do you expect that just like H1N1 to have multivalent vaccine in future?
Yeah, work is going on pan-corona vaccines, which will use multiple epitopes belonging to slightly different variants of COVID, and they might be able to protect us against a wide range of mutants. Yes.
What is this worldwide scenario regarding vaccination of the children?
Okay, I think the Indian government has probably taken a very wise course about vaccination in children. Should we vaccinate children at all because they have very low risk from COVID? The answer is that COVID is going to be with us, and even children need to be prepared for that. They need to attend school, they need to attend college, and they need to have the immunity developed against COVID, which is going to be with us for several years from the looks of it. And the safest possible vaccines with tested and tried technology like the killed virus vaccine should make sense that it would be the first to be tried in children, and that is what Indian government is doing. But having said that, already mRNA vaccines have been tried in younger children. They have been found to be fairly safe, and the programs are proceeding in US. And yes, vaccination of children should be considered, and the programs must develop further.
Thank you, Dr. Anand. Now, my next question is to Dr. Jami. Dr. Jami, what was your assessment of how the government around the world have handled this pandemic? Were there any opportunities missed for future?
Interesting question. I'll keep it brief if possible. I think it's been a mixed picture. As I said earlier, most countries sort of scrambled after initial delays and denials to contain the epidemic. Stay-at-home orders, lockdowns, closures of transport hubs and transport structures were all used probably in retrospect, probably wisely, but also to an extent, extraordinary civil control powers were adopted by governments, and they were used in some places for political reasons as well. The resulting economic hardship, loss of livelihoods and loss of earning potential were addressed in a variable manner by different countries. Some countries did not do much to ameliorate the economic hardships, and therefore that resulted in a widening health inequalities and widening income inequalities as well. We are just slowly now picking up the pieces from that economic fallout, if you like, and that is every bit as important as the pure health impact of the COVID-19 pandemic. I don't believe many governments acted in the best possible way or made the best possible response to it. But that is all in retrospect. At the time, governments did what they could, and given the sort of resources that they had. In terms of missed opportunities, I think I'll keep it simple again. I think the biggest missed opportunity has been not to use the pandemic and the experience of the pandemic to build public health infrastructure where they were lacking. I think in many parts of the world, it was left to the private sector to rise up and cope with it. India in particular went down the route of an insurance-based model of providing healthcare, basic healthcare, and so on. The American experience would suggest that that is not the most efficient way of delivering good, effective, basic, minimum, high-quality healthcare to the largest number of people. But we chose to go down that route, and many parts of Africa and other parts of the world certainly were not, in my view, supported enough by the international bodies like WHO, the Bill Gates Foundation, and so on. They all made the right noises, but the right amount of resource transfer, technology transfer for the vaccine development did not take place and has still not taken place. There is still widespread vaccine inequality around the world, and that is really a sad commentary on the fact that despite all that's happened in terms of the last few years, in terms of understanding that our health depends on everybody's health. We can't be healthy when people around us are unhealthy and falling sick. Despite the understanding of those public health principles, there has not been greater concerted action and greater united action by international bodies across countries and by national governments within countries.
There is one question by Dr. Anand. He is asking you that China is still trying for zero COVID. Is it rational?
Yes, that is interesting. I mean, all of us have been looking at that with some concern as to whether they are really going to achieve that. I don't know to the extent to which they are prepared to go down that route and really shut down vast areas. But they've always done things differently, the Chinese, and their government systems allow such things. Even a simple vaccine mandate, for example, in Canada has resulted in such a huge protests in Canada. And therefore, I don't think that model is replicable in any other part of the world except with their totally authoritarian governments, nor would I, as a public health advocate, recommend it. There are better methods of controlling it. We are coming, as I said earlier, to the end of the whole pandemic scenario at the moment. And so long as we keep our common sense around us and our wits around us and do the basic minimum of right things in terms of building up the public health infrastructure, improving our surveillance and data monitoring techniques, have a little more honesty in data reporting and be transparent with what's happening, and earn the trust of the people, I think we can achieve the golden medium, the golden average, the golden median, if you like, of achieving high vaccination rates without coercion, achieving better reporting rates without making it draconian, and achieving the right public health response without draconian lockdowns in the future.
Definitely in India, because of this pandemic, we had a lot of facilities coming up, and new health facilities are coming. And that's the reason why the third wave or second wave we could manage, though there was a shortage of oxygen. So we had what is called as oxygen transporting the tankers of liquid oxygen from one place to other place where there was a scarcity. Plus now government has made compulsory for every hospital which is more than 50 or 100 beds to have their own oxygen producing capacity. So this is how what we have tried in our India to manage our cases.
Indeed.
Plus in India, if you have seen, we have crossed around 1.5 billion doses of vaccines. So we definitely, India had scores high in that particular thing. And probably that was the reason why India could tackle the third wave, that is Omicron wave, much better than compared to other. Thank you, Dr. Jami. My question is to Dr. Mulinga. Dr. Mulinga, did this pandemic affect any other health problems in your country?
Yes, indeed, Dr. Patel, we had the other health problems, public health problems affected. The biggest which was affected was the HIV programming. You know, we rely on supplies from outside the country, especially India. And with the lockdowns, we did not have commodities available. We ran out of HIV medicines, and we had to switch individuals who were on certain ARVs to another set of ARVs. We also ran out of test kits for HIV and also viral load testing reagents as well. We, similarly, we had malaria affected. In fact, the last year was the year when we recorded the highest incidence in malaria cases, including mortality, for the past 10 years. Something which we thought was down, we saw a resurgence in the cases of malaria, largely because of COVID. We did not have nets available. We did not have drugs available. Then also there was a shift even in the human resource, especially when we are fighting the third wave. We had to move a lot of doctors, nurses, other support staff to COVID isolation centers, leaving these other health problems unattended to appropriately. We had also experienced a similar picture in the TB programming as well. Some of the TB drugs were not available, and largely because we rely so much on the outside help for commodities to be available. In fact, for Zambia, we are landlocked. We only had Ethiopian Airways as the only carrier of the various commodities for HIV, TB, COVID, and we really suffered, and we have seen a negative trend. When you look at the new cases we have had for HIV as well, they've increased. We used to be at 92% for those that were tested before. Now we are at about 84%. The number of deaths as well did increase due to HIV-related mortalities. So we think that COVID negatively impacted our health systems. Thank you.
Definitely, due to lockdown in India, many cases of which used to be caused by eating junk food were definitely on decline, because that shops were, these hotels were not open. Definitely, it has affected it somewhat positively in India, because other diseases were seen on decline. So my thank you, Dr. Mulinga. Now my next question is to Dr. Kirtida. Do diabetic patients require any other vaccines apart from COVID vaccine?
Yes, it's advisable to give them a flu vaccine and a pneumococcal vaccine. So if they've already had the COVID infection, it's good to wait 4 to 6 weeks at least after the COVID infection. But diabetic patients do need, it's advisable, especially now in a COVID, then a pneumococcal vaccine, which is valid for up to 3 to 5 years.
Yeah, thank you, Dr. Kirtida. My next question is to Dr. Mumtaz. Dr. Mumtaz, what were the lessons learned by our fraternity? Did this pandemic made them tough in their resolve to fight in future any such pandemic?
Well, that's a difficult one, isn't it? I think it probably tested our resilience in different ways. And perhaps for some, it's made them more resilient, but others, it's, there's been a significant impact on their, personal well-being, as well as, all the other, we talk about the parallel pandemic, as in, kind of the impact on the healthcare staff due to the pandemic as well, because of, severe mental health issues, depression, anxiety, all these things as well. So I think lots of learning to do. I think what's been supportive is that camaraderie. The reason why I went into medicine, the team working, the peer support, those things have been very positive. I think particularly in my organization, as well as the wider organizations that I support. So through the Royal College, through our sort of universities, postgraduate institutions, that support, wider support being provided has been good. And the networking, I think COVID's opened a number of doors, particularly with technology and things. So we've been able to support, kind of, and hold, meetings like this. We had lots of COVID stories, webinars, support networks, which were created as a result of it. So I would hope that we are getting better of how we manage it, but the medical fraternity per se, I think, has been impacted significantly, and sort of not all positive, I think negative impact, but it's how we better support going forwards, which will hopefully make the change into a positive one over time. I hope that helps. Thank you.
Thank you, Dr. Mumtaz. Now this will be the last question I'm asking to Dr. Amit. Dr. Amit, it is said that prevention is better than cure. If you can fight any such illnesses, if you have got very strong immunity, will the vitamins or any kadas and whatever will help in boosting immunity? What measures you can take to boost your immunity? Dr. Amit?
I
think he is muted. Actually, he's not able to hear that.
I'm sorry, I've just come.
Yeah. The question was, it is said that prevention is better than cure. You can fight any such illnesses if you have got strong immunity. Will vitamins, mineral supplements, or these kadas will help to fight this or boost up your immunity? What measures will you suggest to boost the immunity?
I think if you take the entire COVID thing with a little of like a silver lining to a black cloud, all it's telling us is to go back to your roots. You need to wash your hands. You need to avoid going outside when it's not really required. Avoid crowds. Eat right, sleep right, exercise well on time. So generally, I feel in a way the pandemic has taught to the entire world what we as doctors were trying to tell them for ages now, that immunity matters, your primary basic health necessities matter. Talking of immunity, the way I see it, it's the three basic pillars of founding of anybody's immunity works upon a regular exercise portion, the correct and the right nutrition for each individual, and a regular daily de-stressing. I think these three things, if every individual listening into us and all of us practice this and preach this, I think that's how we can boost up our innate immunity and fight against this and even further threats that may come in. Thank you.
So what is the take-home message our panelists can give? Can you summarize our meet today?
So I believe it's been exhaustive but very, very informative 2 hours and 15 minutes on the clock, where I believe all of us here have done a great job. So first, let me give an applaud to every panelist, every speaker, everybody for doing a wonderful job. My job to summarize is I think a pretty simple one. I think what everybody has tried to cut across, say, from each country and each specialty is that one, don't be scared. You need to not lower your guard. You need to be concerned, but you don't need to panic or be anxious. I think that's the first and loud, clear message. Number two, vaccines do work. There is no denying it. If vaccinations weren't there, we still would be grappling with smallpox and many other dreaded infections around the world. So I think vaccination is the way forward. Third is immunity, nutrition, exercise. These pointers definitely are here to stay, and they should be practiced. So I believe that was in a nutshell what each and every one of us in his own way was trying to convey to everybody who's logged in to listen to us. And I hope I have done justice to that summarization. Dr. Rajesh Patil, please.
Yeah. Thank you, Dr. Amit. Now we are going to come to this end of this session. If there anybody wants to ask any question, they can just go ahead and ask. Our panelists will answer if they have any questions. I request all our panelists to come on live, because I'm going to take a screenshot of this thing so that we can post it. Yeah, everybody, all the participants who are there, to switch on their cameras. Okay, thank you very much. Now I hand over this. I can say that we have finished our panel discussion, and it was a very interesting panel discussion, and everybody thoroughly enjoyed. I particularly enjoyed this. I got some very new knowledge to to learn, and I'm very happy. I think this is the experience of everybody. Now I hand over to Rotarian Sulan for further proceedings and for giving vote of thanks.
To unmute. She's muted.
Sulan, unmute yourself. Sulan?
Thank you, Dr. Rajesh.
Yeah.
Sorry, I've taken in so much information that I'm still reeling under it. So please excuse this non-medical, non-technical person. Someone has said no duty is more urgent than giving thanks. Someone else has said thank you is the highest form of thought. Today's discussion was an astounding success. I'm still reeling from all that. Lots of information received and shared, lots to take back home and mull over, if not to act upon. And all this was only possible through your commitment of time and effort, which is especially notable given your normal responsibilities. Thank you, Dr. Rao, Dr. Patel, Professor Mulenga, Dr. Acharya, Dr. Bhave, Dr. Saraf, and Dr. Kamal. Thank you to the attentive audience for their active participation. Thank you to Dr. Rajesh, Dr. Nitin, and Dr. Shrikant for organizing and moderating this interesting discussion. Thank you to Ms. Pooja and Nisarg Foundation. And last but not the least, a big thank you to our behind-the-scene team, our club members, led by Rotarian Shankar. Thank you. Can we all please give all of us a big applause?
Thank you very much, Sulan. That was one of the most wonderful experiences I'm sure we all had. Before I conclude the meeting, I would just like to thank all the panel members for their participation in today's panel and giving us their very valuable comments, views, opinions, and expertise on what they went through during COVID in the last couple of years. Also, a big thanks to all our guests who came for this panel discussion and to visiting Rotarians and dignitaries. And last but not the least, of course, to Rajesh and Shrikant and Nitin, as well as Sulan, Swati, Ganesh, and others in the team who made this event as a very successful event. Thank you all very much. I know it is kind of like gone beyond our scheduled time, but thank you all for your patience. I hereby conclude the panel discussion. Thank you once again on behalf of the International Rotary E-Club, District 1210, England. Have a nice day.
I request all panelists to stay behind so that we can share our thoughts once again.
Yeah.
Among us.
Yeah. Rajesh, can we turn down the YouTube live chat, please?
Yeah.
YouTube बंद झाला कसा?
Thank you so much. It was really very, very informative.
YouTube to बंद कर record.
Dr. Mulenga, Professor Mulenga, I hope you've had lunch.
No, I'll have lunch soon. I'm okay.
No, it was excellent. Thank you so much.
So this was really, I enjoyed it, and